Hi, I'm Amanda Devis, and I wanted to thank Dr. Brad Sack, Dr. David Sack today for joining us to tell you all a little bit about their lives here, collectively adding up to almost 100 years. And I just wanted to start asking Brad what it was like when he came to Johns Hopkins in 1962.
It's an interesting story because I was going to be drafted into the war whatever was going on at that time. And because I had some early rheumatoid arthritis, they wouldn't take me. And so I was able to take a fellowship that I wanted to in infectious disease at Hopkins. And so they sent me to Calcutta for a 2-year period with my family. And that's where I first saw cholera. And it being such a dramatic disease, it has sort of kept my attention, much attention, for the last 50 years.
Yeah. So how did you get your baby brother to join in the cholera fight?
Well, I'll have to let him answer that, but I mean, we didn't plan it, I'm sure.
Didn't happen. Did you come visit him here at Hopkins in this?
I had been interested in international health. I certainly did not intend to go into cholera and diarrheal diseases, but at that time, almost 40 years ago, when I started my infectious disease fellowship, there were very few centers where you could study infectious disease with a view toward international health, and Johns Hopkins was one of those few places. So this is where I came, and it turned out that even though I tried not to work with Brad, I tried to work in other areas, but in fact his laboratory was the one that was the most active, and so I did start working with him.
And so you've worked together then for 40 years. Has it been always a brotherly kind of love? Was it always a very good opportunity to work with your brother?
Yeah, I always thought a very, very positive experience. I don't think we ever were at blows against each other's ideas about doing this and that and this, and no, we sort of melded together very well.
And I think in many ways we were doing complementary things. It's not that we were doing exactly the same.
Yeah, right.
Right. And both of you have children now who are physicians as well, correct?
Yeah, I have a son who's an anesthesiologist now.
Yes,
and I have one that's an endocrinologist.
Endocrinologist.
So neither of those have gone into international health.
Or diarrhea.
Or diarrheal disease, no, that's right.
So I think what everybody wants to know is what did attract you guys to diarrhea? Was it just the enormity of the morbidity and mortality associated with the disease?
Well, in the case of my fellowship, of course, it was going into international medicine is what I wanted to do. And at that time, the NIH had a program called the ICMRT, International Center for Medical Research and Training. And they gave large grants to different universities who wanted to work in developing countries. And Hopkins had just gotten one recently. And another person who came with me, Dr. Charles Carpenter, who's now a professor at Brown University. He was senior to me, but he was a junior faculty. But he had just finished a fellowship in physiology at NIH. And I had finished a master's degree in microbiology. So in a sense, that fit very nicely together to study cholera. But again, that was sort of an accident, but it really worked out well because what we got into, we needed both areas of expertise to get involved. And I should just say that I went to Calcutta, the School of Tropical Medicine there. Dave started in ICDDRB, but doing very, very similar things at the beginning.
What was the case fatality rate for cholera when you first arrived in Calcutta?
Because neither Chuck nor I had seen cholera before, we thought before we really get started, we needed to see how patients are treated. And so we followed sort of rounds in the infectious disease hospital, which is a big hospital and was sort of considered the best cholera hospital at that time. And we saw a mortality rate of about 25%. This is after about 3 months of doing this. Now, we didn't try to interfere because these were the experts, but we just watched them. There are a couple of obvious things. You had asked me about this earlier, about dehydration. What we saw in the ward was a couple of huge physical signs that nobody should miss. One is Kussmaul respiration, because all these patients have metabolic acidosis, and they're lying in bed, you know, huffing and puffing. Any physician should know what's going on, but somehow that didn't seem to catch with them. The other thing is that they were yelling for water. They called it jal or pani, and they were actually yelling out loud because somehow they were restricting them from drinking it. And again, I never understood why that was. And they didn't, I think, actually think of dehydration. There were these, I don't know what it was, but because they were giving IV fluids, not what we'd consider correct, but they weren't giving enough, and they weren't giving the right concentration of electrolytes.
I think there were, as I recall, there were a lot of different theories about what kind of fluids, whether it should be hypertonic solution or hypotonic, and what the, you know, how much of potassium, how much sodium, etc. there should be in the IV fluid.
Right.
And I guess if they were missing the Kussmaul respiration, they were also did not appreciate the acidosis that was occurring in the patients.
So the first thing we did, Chuck and I, when we got there, was measure electrolytes in the stool and in the blood. And it was fairly easy by measuring them and knowing the volume of diarrhea that the patients had, exactly how much the deficit was. And so this was the first part of the study. And we replaced what we measured, and from the very beginning, the mortality rate went down to zero, essentially. It was very dramatic. And it was so dramatic that patients, the word got out in the hospital, the patients coming into the hospital wanted to come to our ward. Ours was just a study ward, a 2-bed ward, but they knew the patients that were in our ward wouldn't die. So, I mean, it was pretty striking. And it took, in spite of that, it took the doctors in the hospital a while before they sort of gradually understood what was happening. So it wasn't a dramatic change in the whole hospital. It was just in the patients we were studying.
You know, now we sort of take for granted, you know, sending a blood sample for electrolytes or an arterial blood pH, but that was not a simple thing to do at that time.
Right.
I mean, how did you measure electrolytes or blood pH?
Yeah, we set up local laboratory with simple techniques. We use copper sulfate method for measuring specific gravity, for instance. That's something that's not used. And simple measurements, I can't remember the exact instruments we used, but for sodium chloride and bicarbonate on regular blood. We didn't do arterial sticks to measure that.
So how long did it take from the beginning of your study in Calcutta to start working with your collaborators to develop ORS? I know that you worked with a large group, and there was some studies done prior to your work.
Well, the ORS in Calcutta was 1968. We started in 62, and up until then we just used used intravenous fluids, which kept the mortality down. But the problem, of course, was that cholera that takes place in villages outside of a hospital wouldn't have any possibility of getting adequate IV therapy. I mean, people didn't want to carry the liters of bottles out to the village, and so patients had to be transported into the hospital, and that may take hours. And of course, with cholera, hours makes a difference in whether you survive. So it became clear at that point that what can we do other than IV fluids to make therapy possible. So that was definitely the stimulus. Cholera was the stimulus to the development of oral rehydration therapy.
As your careers have unfolded, and you were around when you guys were working out the ingredients of ORS, and you've seen it save, I'm assuming, millions of lives at this point, but for a broad array of diarrheal diseases, correct? Including ETEC, especially, correct?
Right.
So could you want to tell us a little about that?
Well, we were able to find ETEC for the first time in Calcutta in 1968. And we did it the same way that Dr. Day had discovered cholera vaccine. He'd used an infant rabbit technique, and by injecting either organisms or the filtrate from the organisms into rabbit loops and see that they filled up with fluid, indicating a secretion was going on. So we used, nobody at that time knew much about E. coli, so we used the same technique, but the reason we got interested in the E. coli is that we measured the numbers of E. coli in the stool, and also we put tubes down into the small intestine. Both places we found lots of E. coli. And so we figured there must be something about these E. coli, because of course normal people have E. coli all the time, but these were in high concentrations and in sort of unusual places in the small bowel. So that's sort of, and the patients had a cholera-like syndrome. In other words, the physician seeing these patients, actually the local physicians called them cholera, but they were cholera without the vibrios, so it was sort of called non-vibrio cholera for a while, until we were able to show that these organisms produce toxins, that one of which was almost exactly similar to cholera toxin, and that you couldn't identify these E. coli any other way except measuring for the toxins. That made it very difficult, because with cholera, they're easy to culture, whereas these were not easy to recognize.
How did you teach the physicians to differentiate? I know the treatment is still IV and antibiotics, correct?
Well, the treatment is mostly IV and ORS.
ORS.
For antibiotics don't have as much an effect on the ETEC as they did on cholera. Okay. And we did some early studies because we thought that would be useful in both diseases, but for some reason, studies we were using tetracycline because that's what we found to be useful in cholera. But that didn't seem to make a big difference. But the disease itself, maybe the reason was that the disease itself, even though it looked like cholera, it was a much shorter disease. The amount of stool they put out was fewer liters. The time that they were sick was only maybe a day and a half instead of 3 or 4 days with cholera. So it was, even though they looked like cholera, they would be passing rice water stool and they may be vomiting, but somehow the disease never was persistent. It was sort of cutting off itself. Maybe that's why the antibiotics never really were
probably had some effect, but not nearly as much.
Yeah.
But you asked about the ORS, and that was really, I guess the first studies were done in 1968 also, weren't they? Or first published in 68. But
right.
At that time there was actually, or maybe before then, there was a feeling that in a case of cholera or severe diarrhea, the intestine was absorbing as much fluid as it could. Obviously it was, because it was, everything was coming out and it couldn't absorb any more. And so the idea that you could actually get the intestinal mucosa to absorb fluid when it's having diarrhea, it just didn't make sense to people. And so until they realized that there was this glucose-mediated transport, that's when they began to realize, well, in fact, even in the diarrhea situation, you could still absorb even while the diarrhea continued. But then it was a problem of getting the formula right. Mm-hmm. Because some earlier studies didn't work out so well, and there were many of the important scientists who felt this was not possible. And there was a lot of controversy whether you could even try an oral rehydration solution. So I don't know if you want to go into that and all about the controversy, but I guess the important part was that the studies were done both in Calcutta and in Dhaka.
And how many years did it take from actually discovering its benefits before you got these facilities to routinely implement the use of ORS? I think it was a considerable amount, correct?
Yeah, before it actually got to be used worldwide. And even though the studies were very clear-cut, even India, it took maybe 10 years before all of India knew how useful it was. And of course, WHO was setting up training courses all over the world, and I went to some. I'm sure you were involved in them also, just to treat not just pediatricians but any physicians on how useful it was. In Peru, where I spent about a year and a half, we actually were able to demonstrate there in their children's hospital a very dramatic event. And that when I think back on it, it's more dramatic now. But I was asked to give the lecture on oral rehydration fluid. It was among all pediatricians in a pretty big room, and it was right next to the outpatient clinic. So we had nurses or whoever was taking care of the kids bring in patients that they thought were dehydrated. And so I think at the beginning, we had 2 patients, I think, and both of them were not severely dehydrated, but were moderately dehydrated. And we had actually physicians come down and verify, yes, these children are dehydrated. And then as I was talking, the nurses were feeding these children ORS. And at the end of the lecture, which was about an hour, I think, we had the same pediatricians go back down and look at the kids and say, yep, they're not dehydrated. So I don't know how many people got that message, but it was pretty dramatic. I guess that was one of the things that helped start Peru using oral rehydration fluid for children's diarrhea, not cholera. There was no cholera there then, but just for children's diarrhea. It was due to probably ETEC and rotavirus and salmonella and other things. But so they trained all their pediatricians in Peru how to do this. So that by the time the cholera outbreak came in, was it 91, a lot of physicians in the country knew how to use ORS, and they had a mortality rate which was about 1%. Very surprising, because any other countries in which cholera came in for the first time, physicians didn't know anything about it, didn't know how to use ORS, and the mortality rates were much higher, maybe even 5 to 10% in some countries, so that it was a huge difference. And the only thing we can think of there is that they already knew a lot about using oral rehydration.
So is that what you might see as the difference between Haiti now and Peru in 1991?
Yeah, I think in Haiti, at least at the beginning of the outbreak, the case fatality rates were were very high, and now they have come down. But certainly at the early part of the epidemic, it was more than 5%, and it still is 5% in most parts of Africa, in sub-Saharan Africa. But just getting back to the training program that Brad mentioned, I remember some training programs that we had in Bangladesh, in Dhaka, and we would bring some professors from the region, and these professors were very skeptical of oral rehydration solution at the time. And they would listen to the lecture about ORS, but they didn't believe it. But then part of the training was they would have to actually sit with a patient and administer ORS to dehydrated patients. And they became the evangelists for ORS once they had actually done it themselves. But these were professors who probably hadn't sat with many patients for a very long time. But after they had actually done it and witnessed, how it works, then they became the real advocates for it. So.
One other thing I should mention about mortality rates in cholera, and I didn't say this earlier, but when I said in Calcutta it was 25%. Without any treatment, it was 50%. And it'd be 50% anywhere where cholera hits. And it's throughout Africa that when it first comes and people don't know how to treat it, it can be 50%. This happened in Bukavu, what was that?
Is that in Congo?
Yeah, in Congo, where that was the mortality. They brought in people that could teach him how to treat the disease, and he, again, it immediately fell down and people from ICDDRB went in many of these epidemics to teach the local people how to use it, and mortality rates come down rapidly. So it's one of those diseases where the high mortality can be almost all saved.
What is the barrier between having ORS available to all places with potential endemic seasonal outbreaks and things of this nature, perhaps like sub-Saharan Africa? What is the barrier to having ORS readily available?
Yeah, ORS should be everywhere. It should be in the local pharmacy. It should be in everybody's home. You know, most of us have aspirin or Tylenol or ibuprofen in our medicine cabinet. And similarly, we should all have oral rehydration solution packets in our home, but we don't. And this was, I think, one of the discouraging parts of the Haiti outbreak is that emergency shipments of oral rehydration solution had to be shipped into Haiti. Well, when you think about it, I mean, diarrhea has been there. It's not new. So ORS should have been available already, and it should have just been implemented, you know, when cholera appeared. There really shouldn't be any constraint, but in fact, you know, if we look at the surveys now, the demographic health surveys, the DHS surveys, in sub-Saharan Africa, only about 30% of the episodes of diarrhea are treated with ORS today. I don't think it's an economic barrier because it's very cheap. I think it's more a matter of just learning and understanding by families. You know, if you look at all the developing countries, the one outlier here is Bangladesh. And in Bangladesh, about 80% of children with diarrhea receive oral rehydration solution. And I think now what's happened is that every family in Bangladesh knows about ORS. So children growing up, they know about ORS, and when they grow up and become parents, then of course they do it because it's now part of the folk culture. But unfortunately, in most areas, that's still not the case. And in fact, we still have trouble here in America with ORS, where it's not really used very appropriately. It's still much underutilized.
One of the reasons that slowed down the implementation and widespread use of ORS was convincing, particularly the pediatricians, that this, even though, as Dave was saying, they had to see it, but that wasn't enough. They had to see it in the textbook of pediatrics, and those are written by US and UK. And so Dr. Matthew Santosham and I spent a lot of time going to pediatric conferences and talking about ORS. And eventually, when it finally got into the textbooks, then people would believe it. People like to believe textbooks. And I think at least we're past that barrier anyway.
Right. Yeah. It was amazing how long it took to get into Nelson's textbook of pediatrics. I forget which edition it finally arrived, but it was way too long. Yeah. There was a barrier too, in that, you know, at first it was used for cholera, but then there was a feeling that, well, you know, we don't have cholera here. Maybe we have rotavirus or we have some other cause, and we're not sure that ORS will work in that disease. So there had to be a series of studies to show that, yes, it did work in rotavirus. That was done in Bangladesh. Another study was done in Central America. And then there was the other problem that, you know, not everybody had a packet. Or early on, there was a big argument. Do we need to have the packet which contains glucose, or can we make a solution using ingredients that we find in the home?
So after all of this talk about your pivotal role in the development of ORS, I was hoping you could share with us the story of your experience with cholera. And did you have the ORS packet handy?
Well, I had the ORS packet with me because every time I travel in that part of the world, I always carry some ORS packets with me. And but when this started, I thought, I probably just had traveler's diarrhea, and so I took my antibiotics and I took the Cipro and had my ORS. But I should say that before that, this was about 4 o'clock in the afternoon. The day before that, I had lunch in Calcutta at a 4-star hotel, and then took a plane to Dhaka that afternoon. And then I was attending a seminar in ICDDRB by Dr. Dick Finkelstein, who's a sort of a microbiologist, well known, who's worked with cholera for many years, and he was the one that actually taught me what a Vibrio looks like. But when I was listening to the conference, I felt I had to go to the bathroom, which I did, and then it just kept going on, and so I had to leave the conference and go back to the guest house where I was staying, and then started taking ORS that I had with me, and the diarrhea just continued, and I got weaker and weaker, and it was harder to stand up. So, and eventually got a lot of pain in my muscles in my thighs from standing up, and so I just had to crawl down on the floor and crawl over to the porch and call for help. So some of the staff members at the guest house came and they realized what was happening, and I explained what was happening, and they called an ambulance and took me to the ICDDRB hospital where they put in an IV. And it took, I was there for about a day and a half, about 36 hours, I think, in spite of the fact that I took my antibiotic at the very beginning of the illness.
Did you spend the whole time on a cholera cup?
And I was on a cholera cup.
The whole time?
Yes.
Oh, wow.
Yes.
Yeah.
As long as you're having diarrhea, when the diarrhea stops, of course, you can get up. But the nice thing about it was you didn't have to get up, and they were able to measure the fluid in the bucket under the cot, so that they knew exactly how much fluid to give you. They didn't have to weigh you or anything like that. And so that, as I look back on it, I realized that I had a very dietary indiscretion when I chose to take shrimp cocktail in Calcutta that lunch, and on a real hot day.
And you took a shrimp cocktail in Calcutta.
Yeah, right.
Not a good thing to do, even at a 4-star hotel.
Yeah.
Sometimes how fancy they are can elude us from.
Just to highlight again the cholera cot, though, I recently met Dr. Ray Watton, who was the inventor of the cholera cot. Back, I think it was in 1959 that he used it. It's a very efficient way to measure intake and output, and it's probably saved more lives, from diarrhea than almost any other simple medical invention. So.
Purely by the fact that it allows it to go into a secure place, allows you to measure how much has been lost, and prevents further contamination.
Right, yeah. So, and the principle when you're treating someone with diarrhea is you need to replace the volume that's being lost. And this allows you to measure how much is being lost, and then you can replace that amount.
So on that note, I guess one more question would be tropical diseases, diarrheal diseases, which is obviously you guys' main interest, but amongst your family, with all of the living overseas and traveling overseas, what other varieties of pathogens have you encountered?
Yeah. Well, our family, I think we all four, when we were living in Dhaka, we did get shigellosis from eating at a Chinese restaurant in town. Both my wife and my daughter have had malaria, but fortunately they were well treated and they did well. I think that, Brad, you mentioned that your family had dengue.
Right.
And I suppose we've all had traveler's diarrhea from time to time, but that sort of goes with the territory.
And I had two of our children develop TB from Calcutta, but they were caught very early and were treated well and had no problems. But we actually had to leave early because our daughter needed some more treatment. So those are the only other ones.
It turns out that my son had tuberculosis also, or at least he converted,
Yeah.
but not overseas. He did that as a medical student at the University of Maryland.
Oh, wow. So, and which would you say is the worst, Shigella?
Well, Shigella is I don't like to have Shigella. That's very painful. It's not dangerous for an adult, but it's certainly, it's really painful with painful cramps and, very frequent, trips to the bathroom. So it's not fun.
Before we wrap up, I wanted to ask you a little bit, as your career began with cholera, correct? And you have, since then, while still working on cholera, you also work a lot on rotavirus.
That's right, yeah.
And we all know about the rotavirus vaccine, and it's being implemented all over the world. And
Yeah.
what would you want to share? What stories or?
I mean, rotavirus was only discovered, in our lifetime, so we haven't known about it that long. And it is, right now we believe that it kills about 400,000 children each year. So there's a tremendous opportunity for the vaccine to work. Unfortunately, the vaccine does not work as well in countries with poor children as it does in America or Latin America. So we still have a ways to go to understand that. But even in spite of it not working as well, it's still a major benefit to get this out. As you recall, the first vaccine that was tested and licensed had a side effect of intussusception, so that was withdrawn, and we were worried that maybe that would be the end of the research on rotavirus vaccines. But fortunately, the research did continue, and now we have two licensed vaccines, and hopefully we'll have some others in addition. So, I think this is, we don't usually think of diarrhea as being a vaccine-preventable disease, but this is certainly one case where it is. The other illness, or the other infection, though, is the enterotoxigenic E. coli. And that's probably, in developing countries, that may be just as important as rotavirus. It's just that we don't know how to diagnose it so easily like we do rotavirus. And so we haven't made the kind of progress for ETEC vaccine that we have for rota.
And we should say the cholera vaccine, we haven't really talked
Right, that's
much
what I was
about
going to
that.
segue into,
Dave's
but I
been involved in that, and an ETEC vaccine. So both of these have tremendous possibilities for controlling diarrhea.
And the oral cholera vaccine is being implemented in small studies in Bangladesh and Haiti
Haiti and now Guinea, Zanzibar, Orissa, Calcutta.
Okay.
So it is getting out there, but we still need to scale it up and need to learn best how to use it. I wish we had a few 100 million doses that we could distribute widely rather than only a few million doses, which is what's available. But I think soon we will have a good supply, and then we will be able to use it. And, when we think about cholera and the opportunities for the vaccine, and it's how it works together with water sanitation, it should be possible to reduce the R0 to less than 0. Now, we won't ever eradicate it. We won't eliminate it in the sense like we can, do it with smallpox, since it is a bacteria that lives in the environment. But hopefully we could get it down to a level where it is no longer a public health problem.
So speaking of that, before we finish, I just have to mention your work with smallpox. And I know we're talking about diarrheal diseases, but if you could just tell us a small story or two about your experience containing smallpox in Calcutta.
Yeah, I didn't really study smallpox, but I saw a lot of it. I'd never seen smallpox before, and most people have never seen it. But in Calcutta, they had huge outbreaks every year when our whole hospital, the cholera hospital, was turned into a smallpox hospital during that season. And so when we had visitors coming to visit us in Calcutta, we always had to make sure that they had smallpox immunization. And when we took our children there, I had to make sure that they had and I had to take them back several times here to the whatever travel clinic because they didn't really give the immunization correctly, and I didn't want to go until we absolutely were sure they were immune. So, but all the different kinds of smallpox, hemorrhagic kinds, and I don't know now what all the ways they were measured, they were described, but it was just amazing that it was just thousands and thousands of cases.
Yeah, I was in Dhaka at the time, and in 1974, I was working in the laboratory at that time, and the smallpox team came and said, "Dave, would you like to go out with us? We're doing a smallpox campaign." And I said, "Oh, I'm too busy today. I'll do it another day." But that was my last chance to see smallpox, and by the year that I was there, it was gone. It was amazing.
Opportunity of a lifetime missed.
Yeah.
So, based on that, I guess, in your lifetimes and in this immensely successful careers you both have had, what would you say has been the contribution to public health that you're each most proud of, that your brother has contributed?
Well, maybe I'll go first. I would say that for Brad, I would say I'm most proud of the discovery of the enterotoxigenic E. coli, which is, one of the major causes of diarrheal mortality in the world. That plus his contribution to development of oral rehydration solution.
And Dave also was very much involved in the oral rehydration. In fact, studies that you did that could show that it could be used in rotavirus. Before that, the pediatricians were all saying no, ORS wouldn't work with rotavirus patients, and obviously did. And that made a huge difference to pediatricians. The other thing is that Dave, has been working for the last 8 years as director of the ICDDRB in Dhaka, which is a huge international project and thousands of employees, and I mean, for him to manage all of this during this time is just amazing. And he's been involved in all aspects of diarrheal disease. But just to imagine running a huge institution like that and still being able to get work done, that was amazing.
I should highlight ICDRB and just to let people know that one of the old mottos that we used to talk about at ICDRB is to take science where the problem is. And so I think it is a model of carrying out the work that's so important in developing countries, but carrying out the research in the country itself, and not expecting that we smart people in America are going to solve the problems of the world, but rather that working together with the Bangladeshi scientists and with scientists from other parts of the world, working together, but in the setting where the problem is so important. I think look back at the oral rehydration solution story. By the end of 1967, there was a treatment for cholera that was 100% successful, IVs. But it was because people were living and working in Bangladesh and in India, they realized this IV solution, even though it was effective, it's not practical for the setting where the problem was. And this is what led them then to take the next step and to find new solutions for the problem, and not just implement something that just because it's efficacious doesn't mean it's going to be effective in that setting.
Right. I've had the privilege, or get the privilege in the next few years, to work with both of you and to study cholera and learn from you. And what would your guidance be, your advice for young PhD students or Masters of Public Health students at Hopkins, and what we should look forward to and look towards as potential areas to contribute to the improvement of health?
I think there are so many possibilities out there so many diseases that need vaccines, that need better treatments. There are a lot of particularly tropical diseases that we don't have good treatment for. And I mean, these are so important, but also training of people and how to manage these sort of public health issues. And for research, since I've been doing research all of my time, is to be persistent with NIH. It always takes, not an easy thing to get NIH funds, and you may get rejected, but you just keep rewriting and be persistent, and it'll usually be successful. So, but it's really hard for young persons starting a research career now, so that they need really to get themselves involved in projects and other people who are already successful in that area.
I think that, there are so many opportunities. It's a little bit like a kid in a candy shop. There's so many directions that one could go. But I think if you get good training, and if you see an issue that really you find is really important, to really go after it. But to gather your resources, make your connections, make your collaborations, and to learn from both, people here as well as people you'll be meeting overseas, and to learn from as many people as you can. But as Brad says, it's persistence. And I think sometimes people, would ask the question, well, how do I make the right decision about the choice of my research topic? And, one thing to think about is it's not only a matter of making the right decision, but after you make the decision, how can you make it right? and really, really go after it and take it for all it's worth.
Mm-hmm. I feel like we need diarrhea superhero capes for both of you, for all of you done over the past 50 years. But thank you very much for your time. I know that the students will immensely enjoy getting to know you both the way I have. So.
Thank you. Okay. I'm glad we could participate.
Thank you.